Okay, hi everyone. My name is John Giraldo. I'm the Senior Manager for Henry Schein Orthodontics for the region of Canada, Spain, Portugal, Central and South America. Today I have the privilege to share the screen with Dr. PERI COLINO. Dr. PERI COLINO currently is the Director of the Digital Orthopedic and Orthodontic Master Degree at the University of San Antonio de Murcia. Currently, he is the writer of 5 books. 3 of them are on the orthodontic topic, and 2 of them are on anthropology. So, due to the crush time, the screen is all yours, Dr. Colino. Thank you for being here with us.
Thank you very much. For me, it's a pleasure to stay with you again and to talk about one of the most important topics that we have today in orthodontics is the how can we manage the technology, how can we manage the 3 dimension in an orthodontic patient. It's not easy for us to become to a new system, to a new way of treatment. So starting, I have to say that nowadays there is three important things that we have to do, because all the diagnosis depending of the medias, the media that we have in our office, all of our diagnosis is going to depend on the quality of the photograph, the quality of the intraoral scanner, and for sure the quality of the CBCT. So if we have all the technology with us, is going to be easier to diagnose, is going to be easier to manage a difficult patient as I come to show you. Okay, so sagittal first is our way of work, but it's not our way of diagnose. Okay, it's a spectacular system who help us in how to solve the malocclusion, but they don't say anything about the diagnosis. So technology is the tool that we are going to use in order to become more efficient and can make the sagittal first in the best way. Look at this is what we do nowadays in our master in orthodontics. We are doing 3D diagnosis, indirect bonding of all our patients, with intraoral scanner for sure, and good quality photographs. With all of this, we are going to reach precision in the diagnosis, and for sure we are going to obtain precision as well in the treatment protocol. Look at this patient. Look at this patient. This is not a difficult patient, as you can see, but this one, he was my first 3D patient, my first technology patient, as I can say. Okay, why? Because I do my 3D diagnosis, and I do as well indirect bonding, and I do as well after the bracketing, after the bonding of the bracketing of the brackets, I do the digital smile design, and after the digital smile design, in the last date of the patient, we had the possibility to make the aesthetic in the laterals, as you can see here. So when we do treatment like this, as you can see, when we have the opportunity to do aesthetic, just finishing orthodontics treatment, look at this patient. We are going to solve all the problems that the patient have. Remember that when the patient come comes to the office, they are demanding aesthetic. For sure, they are demanding also function, but the 90% of the patients want aesthetic. We need to give them function, but also we need to give them aesthetic. If we do in the last date and we offer the aesthetic in the same date that we make the debonding, we can finish cases like this. You can see in 4 months of treatment from October to February. This is really good for us. This is really good because this patient is going to send us much more patients for sure. So is really important the 3D diagnosis for us, or is only marketing? As Dr. John says before, the 3D is a useful tool, and I'm directing the ortho program, but I also like to do everything under the research. Okay, so I really like to check everything with research, with the best articles that we have, also in the 5 best journals in the world in orthodontics. So when I make the research, I try to answer this question: is it the 3D useful for diagnosis? Is it useful? Do I have more information when I make a 3D diagnosis than when I make a 2-dimension diagnostic? So if so, for me, it's worth. It's not. I'm not going to spend a lot of such amount of money in order to check something, to buy something that it doesn't do anything new for me. So look at this case. This is an important case for me, and in this case you are going to see that it's completely necessary the technology to access or to solve this situation. She has an impacted canine. So imagine the situation. Imagine the situation that I don't know where is the canine. If I don't know where is the canine and I make a periapical, it's not so accurate in order to take the canine and to make the traction from the canine to the right position. So here I have the opportunity, as you can see, I have the opportunity to know exactly the position, the 3-dimensional position of this canine, in order to take the canine and put in the right position. When I have all of this information, for me, it's much more easy to approach this case. Are there an easy way to collocate, to make the position, to put in the right position the canine? Look at. If I see the literature, if I see the articles, I can see many ways of take a canine. For me, there is a very easy way, even easier than this one. Sometimes when it's from palatine, it's more difficult for us, okay? But this is really easy to approach. Look at. From here, we have the possibility to make the traction with this. I have elastics, so why not using elastics here to make the transportation, the canine, to the right position? Look at this patient now, and look at this patient at the end of the treatment. If you see the image, 1 second, if you see, you are going to see that the canine, the right canine, is exactly in the perfect position, and we make the traction. Look at, we make the traction, make the treatment in less than 1 year. Okay, from that position, this is the deciduous one, the birth one, to the definitive one. Look at 11 months of treatment, less than 1 year. In less than 1 year, I can solve malocclusions like this. Is this easy to do? For sure, you have to learn to manage this 3D technology, for sure. I'm completely sure that it takes some months in order to understand all of the technology and in order to put in action, to put in your office, in your daily practice. But when you have in your daily practice, it becomes really easy to diagnose, and also it becomes really easy to proceed in order to make a good diagnosis. So now I've shown a patient who is necessary, absolutely necessary, to make a 3D diagnosis. Is it necessary to know the 3D position of the jaw? Wait. In 1899, okay, Dr. Angel says the establishment of a normal occlusion of the teeth should be the highest aim of the orthodontics. Now we know that it has to be an objective that we have when we are doing orthodontics, but it's not the only one objective. It's not the only one. We need to obtain function, we need to obtain a class 1, but we need to obtain also a 3-dimension patient, not a 2-dimension patient. So for us, it's different. The approach that Dr. Angel has in 1899 is much more different for us. Now we need to make a 3D diagnosis. And in 1976, Hounsfield was the one who wrote the historical notes on computerized axial tomography. Okay, computerized axial tomography. The same year, maybe you can recognize this. That guy is Steve Jobs. The 1st of April of 1976, Apple was born in the USA as a company. So in the end of 90s, what we saw is that there is a revolution. There is a medical revolution for sure, but there is also a technological revolution. And for us, it's really important to know that we depend on the technology in order to can have more information. Imagine the situation. When we talk about sleep disorders, we need to know that there are 88 currently described disorders. From the 88 disorders that are described, we can only approach 3 disorders. The first one is sleep apnea. Sleep apnea, we can do something in order to solve the sleep apnea, to improve the sleep apnea of a patient. Bruxism is other one, and snoring is for sure other option that we can solve in a patient. When we have hypopnea, we are going to see the image on the right. When we see sleep apnea, we are going to see in the polysomnography, we are going to see a line. It's not working. The breath is not working. Okay, and in the left side, you are going to see a normal breathing. So the oral breathing and the sleep apnea has strong relationship with obesity, with cardiovascular disorders, with hypertension as well. So we need to be focused. We need to be focused in the diagnosis. And we only have one tool in our office in order to diagnose the volume of the airways. If we check in the research, we are going to see that there are a high relationship between airways, volume, and sleep apnea. Okay, so if we have a cross-sectional area less than 50 square millimeters, we have high risk to suffer sleep apnea. If we have between 50 and 100 square millimeters, we have moderate risk to have sleep apnea. And if we have more than 100, between 100 and 150, yes, square millimeters, we have low risk. So when we see a patient with 50, it's a problem for us. We are not the specialist who has to diagnose this patient, but we are the one who has to say, okay, I recommend you to visit the sleep doctor in order to make you a polysomnography because you have a high risk to suffer sleep apnea. So I give you my CBCT and I give him my CBCT in order to improve the diagnosis. And I want to show you the relation between expansion and the improvement of the airways. There are many articles which say that there is a relation between expansion and increases in the volume of the nasal cavity. So here we have an option in the treatment. We have an option in the 3D diagnose in order to make the diagnose, but also we have an option to offer to the patient if we diagnose a problem in the nasal cavity, in the floor of the airways, in the floor of the maxilla. Look at this patient. This patient has a problem. This patient has a breath problem, okay? For us, we have the necessity to treat the airways in this patient. If we focus in the minimal area, we can see that the minimal area is 59. It has between moderate and high risk to suffer sleep apnea. So what we need to know is that maybe he needs help. He needs help, but it's not orthodontics help. It's orthopedic one. It's orthopedic help. We need to make the maxilla bigger in this patient, and we make to send the jaw into the front. Look at. This is the position, the black area that you are watching, the minimal area that you are watching in black, correspond with the jaw position. So imagine the situation when the patient came to my office. I said, okay, your minimal area is very, very, very small. So I recommend you two options. Or you go to the otorhinolaryngologist and talk to them in order of make something. Or we can try something as well. We can make an expansion and we can make an advancement. But let me check if an advancement is worth for you. So I make a second CBCT in this patient in advancement in order to see if to simulate the advancement and see and check if the minimal area is going to improve. And look at the results. The minimal area go to the double, becomes in the double. So when I see that it really works, is the moment when I decide to make my treatment protocol. And what I'm going to do with this patient? I'm going to make a disjunction, and after the disjunction, I'm going to make an advancement with the class 2 motion. And you can ask me, Peri, why didn't you put first the motion? I can do as well, but I prefer to treat before the basal area, okay? Because if I treat the basal area, if I make the maxilla bigger at the beginning, I have the opportunity to allow the jaw to grow in an easiest way, okay? That's the reason I decide to make the disjunction at the beginning, only for the basal, not for the interchange. So after the disjunction, I obtain 100 of minimal area. Now we don't have moderate and we don't have high risk to suffer a sleep apnea. So for us, it's perfect, okay? It's really good for us. Look at the patient after the disjunction. Look at the patient after the disjunction. Look at the volume. We improved the volume in 5 points from 8.9 to 13.3. And look at this patient after only the first step. Now I'm going to make the advancement with the motion. So I'm going to use the motion in order to put my jaw forward, okay, and to correct the class 2 that we have. It's perfect. This is the patient after that, after 3 months. So it's necessary the technology in order to diagnose the position of the jaw. The technology for sure is important, is the key to diagnose a volume problem. And when we offer the option, we need to think about. When we think and we spend a lot of time thinking about that, we are going to give maybe a simple solution for a difficult problem. And for me, I compare the motion, the class 2 motion and the class 3 motion with the best companies in the world, the best application apps in the world. Why? Because WhatsApp, because Instagram, and because Amazon are 3 companies which offer something very, very, very simple. WhatsApp, messages. Instagram, photograph. Amazon is traveling with different things that we want. Allow you to buy something and have in your home in 3 weeks. So this is something simple. What motion gives to me? Simplicity. The motion say to me, PERI, in 4 months, I'm going to put you in a class, your patient in a class 1 platform. So are there any more, are there anything, or is there anything more easy in orthodontics that it start a second phase in class 1 platform? For me, no. Look at this patient. Complete class 2, that when we start, we are in this position. When we continue, we correct the class 2 here. And when we put the second phase, when we put the Career SLX 3D, this patient is really easy to finish, because this is about finishing. This is not second phase, this is finishing in a class 1 patient. So we have the option to do that. And it's simple for us as well, because allow us to spend less time in office. Look at, this is the time that I spend in the office nowadays. I spend 25% of my time here and there in the office. The 10% I've spent in the university. The 15% I spend in the master, okay? The 35% I spent last year giving lectures abroad. And the 15% of my time I spend in my free time. So the 25% of a week is 2,100 of minutes, and I have to see 450 patients in 2,100 minutes. So it's the same to say, it's the same than conclude that I have to spend 4.5 minutes for each patient. So I cannot allow to use systems that make me spend more time with patients. I cannot allow that, okay? This system is really easy system in order to solve. Look at, this is a really easy system to improve the profile, to correct the class 2 or the class 3 of the patient, and to start a second phase, okay, in an easy way. I think that everybody has seen this video, but I like to put because it's a show in an easy way how it works. From here to there, we correct the class 2, okay? And what do we do? This is what we do. We make a rotation of the first molar, we make a distillation of the canine and the first molar of the posterior area, and we correct the class 2. And also we invite the jaw go to the front side. So look at, this is the rotation, and we cannot over rotate because of that. because of that point. It's really easy. It's really easy to use, and it's a simple design who make us to correct it in the best way. So 5 years ago, I made a research and I published in the Spanish Society in order to see the 3D effects of class 2 carrier motion. And look at my conclusion. I present cases in 3 dimensions and I make a superposition using 3 points in the palatal. And we conclude that the motion appliance carrier produce a distalization of cuspids and molars. First. Second, the motion appliance carrier, the carrier motion appliance, increase intercuspids and intermolar width. Why? Because when we make a distalization, we have a more transversal dimension between canines, and we have more transversal dimension between upper molars. And it's probable that there were also mandibular reposition. Why? Because if we have 5 millimeters of a class 2 patient and we improve only 3 millimeters in the upper arch, what is happening in the lower arch? Something has to happen in order to correct the class 2. So that is the reason we said that probable that the mandibular that suffer a mandibular reposition. So I remember that in 2015 I visited Dr. Luis, who is exceptional clinic, and his exceptional clinic, and I spent some days with him, with the team, and we were talking about the system and talking and watching and checking patients and do clinic. Okay, so it was very interesting for me, because when I arrived, Luis told me, Peri, just 1 week before, Dr. McNamara left to his home with information about patients in order to make a research. After that, we had the possibility to see the research that Dr. McNamara made, and for me it was very worthless. Okay, for me it was very good to read this article, because help me to understand what is happening also in the craniofacial complex. It's not only dental. Okay, if we bond a motion in a growing patients, we are going to obtain growing as well. If we put motion in a non-growing patient, we are going to obtain dentoalveolar change, and sometimes we are going to obtain reposition, a small reposition of the jaw. So Dr. McNamara conclude that carrier motion class 2 and carrier motion for class 3 is effective. He concludes as well that changes are produced in craniofacial complex with high variability between patients, and he concludes that the median time from motion is 5 months. So we have to be in account something which is critical. Is the elastics. We need to use the elastic 24 hours. We need to change the elastic 3 times a day. So 3 times a day. And we need an Essex in order to make a posterior disclusion. If we make a posterior disclusion, we are going to eliminate the interarch friction, and the teeth are going to move faster. So what clinical advantages I have when I use a motion? I correct the class 2, I improve the overbite, I change the occlusal plane, I avoid the secondary friction, I avoid or eliminate the static friction, I have some effects in the TMG, I improve the profile balance, and for sure I make a wider and longer arch, as we conclude in 2015. But what's happened in 3 dimensions, because all of this is clinical, what happened when we see a CBCT? Dr. Atia saw that there are an improvement of the airways. Look at, there are a 34% of the increase of the total volume, and there are as well a 23.45 of increase of the minimum area. This is perfect for us because the fact that we know that we are improving the quality of life of a patient, for us is perfect. For us, it's the best new that we can have. Okay, so Einstein says insanity is doing the same thing and thing over and over again and expecting different results. So it's the moment to understand that we can try something simple and different. We are doing something different nowadays in orthodontics. We are putting screws in all the patient. But why can't we go to something easy? Why can't we go to something easy? Is it necessary the screw for everything? Look at, we have a non-surgical protocols with pressure in the palatal center, in the palatal area, to make the junction without screws. Imagine. It's needed in some kind of patient, some types of patient, but we can do, and we are making a protocol. We calculate the turns that we have to do. We check after the 20 turns, and then if there is clinical signs, we make the disjunction. If we see interincisal diastema, we can continue. If we don't see, we need to make a radiographic check-in and see what happened. If there is a problem, we stop the turns and we offer or dentoalveolar compensation or we offer extraction. This is simple. Okay, we do many disjunction nowadays, more than 20, and we are watching, we are seeing things or shutters like this. For me, this is open. For me, this is parallel. For me, this is perfect patient. This is the perfect patient for me. The best patient is this one. There is no maxillary deficiency now. So, something important, when we make the correction of a class 3 patient, we need to respect this angle. Look at, this is really important for us. We need to respect the sulcus, okay, between the chin, okay, and the lower incisor or the lower lip. And look at this patient. This has suffered 4 years ortho treatment before, and he says me that he cannot eat. Okay, and for sure he doesn't want to wear brackets for 4 years again. So this is not an easy case. Look at the situation. When we analyze the face, we are going to see that there is a increased lower facial height. In the 3/4 photos, we are going to see, look at, that there is no cheekbone. Okay, difficult to see the cheekbone. And when we see the profile, we are going to see that the lower lip go forward when they smile, when he smiles. Okay, so let's go to the occlusal pictures, or the occlusal photos. Look at the midline. Look at the class 3 in the left side. Okay, we have open bite, we have midline shift, we have a class 3 molar and class 1 canine. Okay, class 3 molar, but class canine in class 1. And we have the reduce the overbite and reduce for sure the overjet as well. If we see the profile, if we see the intraoral scanner, we are going to see, okay, we are going to see this situation. This situation says us that there is strong contacts in the posterior teeth and there are no contacts in the anterior teeth. The transversal between premolars, first premolars, are 26 millimeters, and the transversal between upper molars and first molars is 33.8 millimeters. So when I see the set, I'm going to see a Dolicho class 3 patient, and McNamara remind me that each millimeter of increased lower anterior facial height camouflage 1 millimeter of increased mandibular length. So be careful with making an anterior rotation of the jaw, because we are going to see the real class 3 that the patient really had. So I again I came back to read the articles in order to see how can I approach this situation. And we can see that in non-growing patient there are two options: or I make surgery or I make a extrusion of anterior teeth. Okay, let's see what's happened when I make surgery. When I make surgery in long term, I can see that the maxilla seems to relapse moderately vertically, and also the mandible seems to relapse both vertically and also sagittally, particularly in both jaws have been operated upon. Overbite seems to be more stable or may even increase when only the maxilla has been operated. So I have an option to do is I can improve or maybe improve or stabilize the overbite, okay, if I treat the maxilla. So what I offer, I remember you this slide. I'm going to offer the simple solution, okay? I can offer a complex, but you know what is going to do? What do you think that he's going to do? He's going to say, Peri, I said you before that I'm not going to spend 4 years, or I'm not going to spend to suffer a surgery or to suffer again because of my past in the ortho, because of my ortho past. So what I offer something simple. I offer this: make a disjunction and make a distalization at the same time, sagittal first with basal treatment. Look at, okay? This is what I offer. When I offer this, the second phase become really easy. Why? Because there are no maxillary deficiency, and because there is a class 1, even a class 2 platform in a class 3 patient after the first phase, after the sagittal first. Look at the situation that we have after the sagittal first. Look at, I have a class 2 patient. Look at this patient. Look at this situation. I have a class 2 situation. So for me, it's really easy. I'm going to close the diastema. I'm going to use slight elastics in order to solve this situation. And look at February, May, June, September. I'm going back. September, beginning, June, May, February. So I start with a light, with 15, with 14 Cooper nitride. I'm going to a square 2020 now. I use in this patient 14 by 25, but now we are using a square arch, a square wire. Look at this occlusion. Look at this finishing and detailing, and look at this situation. Look at this situation. Look at this occlusion. It looks like it's going to be very stable. I don't know if the patient maybe in 10 years can lose maybe the incisor position, the incisor overbite. Okay, but I'm completely sure that he's not going to have a transversal problem. Why? Because I improved the basal. Look at the beginning, and look at also at the end of the treatment. Look at the face. The face is perfect. The face is harmony. Now he can smile with no problem, with no proportion problem. Look at the symmetry of the smile. It's perfect. The symmetry is perfect in this patient. When we see the cephalometrics, we can compare. What do? We change the occlusal plane. When we see the intraoral scan, now Here we can see that there are contacts in all the teeth. So remember what Frankie and McNamara research group says, that open bite subjects present with a significant constriction of the maxillary arch. So when we see a class 3 dolicho patient, the first thing that we need to see is the maxilla, okay? And we are going to treat for sure the sagittal first, but also see the maxilla, the transversal of the maxilla and the volume of the maxilla. We have the opportunity to see that. We have the opportunity to make the measurements. Look at this intraoral scanner. After and before, all the color that you see, red and yellow, all the things that you see in yellow and red are more than 2 millimeters. And this is the situation at the end of the patient. If you see the palatal area, the palatal area is wider at the end of the treatment comparing with the beginning of the treatment. And here I have my patient 1 year after treatment. Look at this situation. This is something that makes me think. I lose 1 millimeter of overbite, as you can see. Look at 1 millimeter. But my occlusion is perfect. And why my occlusion is perfect? Because the tongue has the opportunity to go to the real position, to the perfect position. So for me, it's perfect. When I have the tongue in the palatal area, it's perfect because I'm going to maintain the transversal of my patient. But at night, I like to put this appliance. This is called Morales, okay? And you can see, or you can order in your lab with no problems. I use at night, and you can see something acrylic. You can see some acrylic in the palatal area in order to make the tongue to put in the palatal area, in order to apply the tongue to go to the palatal when they are going to make the swallow. So it's perfect for me. Here you can see how technology helps us in order to understand what is happening and help us in order to understand, look at the millimeters of the distalization of our patients. For me, this is gold because I have the information, and information is predictability. So technology is perfect for me. I know that I've changed the occlusal plane 4.5 degrees. I have improved the transverse dimension of 4.1 millimeters and 4.6 between premolars. And I closed bite 5 millimeters from the beginning. Look at my treatment protocol. Disjunction, 1 month, sagittal first with career motion, class 3, 4 months, and in 5 months, I remove everything and I put SLX, 8 months. Total treatment time, 30 months. 30 months. So it's important to say that there are limits, okay? When there are limits and when we have when we are very close to the limits, in that situation, not in the past, not in the other situation, in this situation is when we need the skeletal anchorage. But not in every situation. It's a tool, it's a great tool, but put screw in all my patients is not the best way to talk to my patient and say, okay, it's perfect for me. I'm going to put you 4 screw and I'm going to spend 1 year. Okay, it's easier to say, hello patient, I'm going to put you 1 motion and then brackets or then aligners, and in 1 year I'm going to finish you with no screws, with no surgery, with anything. Okay, the patient is going to say, I prefer no screws for sure. So sometimes we need, okay, sometimes we need the screw. In this situation, I need the screw. Okay, why? Look at. In this situation, when I have teeth wear, when I have the upper lip, and when we have this occlusion, it becomes difficult. Okay, it becomes difficult to solve because this is a surgery. This is a surgery patient. So I remember that when she came for first time 15 years ago, she visited my father, and she asked my father in order to put brackets. My father says, no, you need surgery. And she visited 4 or 5 more orthodontics, and all the orthodontics said the same. So 15 years after that, he came back to my office asking for aesthetic, not asking for orthodontic, okay, asking for veneers. So perfect. My aesthetic partner says, okay, make an intraoral scanner. We made the intraoral scanner, and they said, PERI, I cannot put veneers here because I need an overjet. So it's impossible. In that situation, I called her and I said, okay, come to my office. I'm going to explain what we can do. It's not surgical, it's non-surgical, but it involves some skeletal anchorage. So it's a little bit surgical, okay? So look at, we have positive torque of upper incisor and negative torque of lower incisors. We have class 3, we have maxilla efficiency and mandibular prognathins, we have Barston, improvement of the Barston, positive Barston and negative width. So when I see the widths, I can see minus 9 millimeters. Imagine the situation. So simple solution. Basal treatment, sagittal first, M1, M2, M3, aesthetic. Look at. Okay, I put the moon appliance, great appliance, look at. I put also 2 retromolar screws in the upper arch in order to make the traction and don't improve the torque of the upper incisors. Look at this situation. I give the terms, I give the terms the 23rd of October. This is the situation when we start. This is the situation in January. Look at, from January to March, look at the change of the occlusal plane from here to here. From here to here, I change the prognosis of my patient in a bad prognosis, from a bad prognosis to a great prognosis. Now I can remove my lower carrier motion. I can use my 15 wire, look at, in April, in May, at the end of May, beginning of July, and in the beginning of July, I finish, look at the situation, and we are in the perfect situation now to do the aesthetic. We are in the perfect situation now to give her the great proportion that she deserves. So how can I do this? I can do in an easy way as well. Look at, I can do with technology. This is really simple. I can design digitally. I can help with the digital media in order to do something like this. This is really easy. Okay. Final situation. This one. Look at this situation. Look at this patient. Look at this occlusion. Class 1, midline. We have solved the incredible class 3 of the patient. Over bite, over jet. Look at the change. We have changed from -9 to -2.5. Still class 3, still class 3. But she was surgery patient. Remember it. I cannot change I cannot make a surgery change. Okay, I have limits. So look at the CBCT after that, and look at the treatment time. 8 months and 9 days, and 1 month for the aesthetic. So for me, this is the perfect situation in order to imagine that when a class 3 patient go to your office and you tell them, okay, I'm going to finish you I'm going to finish this case in more or less, I think, 1 year, and you finish in 8 months. Imagine the face of happiness of my patient when you say that him or her that you are going to finish in less than 1 year. This is what happened when we put technology and we put career system at the same time. Look at the change. Look at this change. Look at this profile before treatment and 8 months after treatment. Before treatment and 8 months after treatment. So thank you very much for all of you to stay here in this webinar. Thank you for all the Instagram supporters that are here as well. And now is the moment that if you have some doubts about these cases, about how do we use the technology in order to launch the career system to a high quality solution, and all the doubts that you have, you can write or you can do also in the micro. Okay, I'm going to activate the questions also in the Instagram, and Celine or John, if you want, we can analyze all the doubts that the people have. Okay.
Okay, we'll see if some questions will come through the system here.
Okay.
Someone was saying hi from Israel to you.
Great. Perfect. I've never been in Israel, so I'm looking forward to visit it. It's one of the countries that I really want to go soon as well.
Yeah. Someone had a question here. When do you choose to check the airways on a class 2 case, or you do CBCT as a standard protocol in your office?
No, when I suspect about airways problem in a child or transversal problem in a child, I decide to make a CBCT, not in all my patients, okay? For sure, when I decide to treat an adult and I suspect about dentoalveolar problem or transversal problem, I do as well, okay?
Perfect.
More?
Do you use a slow expansion without mini screws in adults? So I guess removable expander, which I think you said it before, you don't use removable expansion on adults,
No.
right?
No, I don't use removable. I don't like removable because removable is very difficult because they can remove. Okay, so I prefer to bond. If I have to put in an adult, I bond. Or if I really need all the skeletal situation, I need to solve the skeletal situation. Sometimes I do skeletal anchorage, and I can start with skeletal anchorage and brackets, upper brackets, brackets in the upper arch. Okay, those are my two options.
Okay.
Yes.
What type of retainer do you use on your last patient?
In my last patient, I use a Essex, upper Essex. I use a lower fixed retainer and also a removable one in the lower arch, because sometimes it breaks the fixed one and I need to have other one in order to put, and came to the office to put a new fixed one retainer. Okay.
Okay. They're asking here, can you please explain how to use the Miniscrew assistant expansion? Do you use 4 screws or you use 2 screws? And have you had
4 screws.
Any problem with these expanders?
Yes. Usually I use 4 screws. I use the Moon expander, but sometimes I suffer ulcerations. Okay, because of there is a gap between the screw and the palatal, and if the patient don't have very, 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 very perfect cleaning, it can ulcerate. So be careful with the ulceration.
Okay. They're asking me what is your protocol or how you choose to remove third molars on a class 3 case distalization?
Okay, I remove the third molar in all my patients, in all my class 3 patients. I don't extract the third molar in class 2 patients. I don't. I recommend, but I can start a treatment with the third molar, the upper third molar. But in the lower arch, for me, it's obliged to extract the third molar because I have suffered, my patients have suffered a lot of pericoronaritis. I don't know how it says in English, infection around the third molar. Okay.
Okay, so from Greece,
Great.
you use carrier motion always for 5 months or for how long? This
Okay.
depends on
They
the
ask,
case,
okay. Okay.
or on the adults, you use surgical expansion as well.
Okay, I use surgical expansion for adults, okay? Never for children, in my opinion, okay? In children, I do the palatal pressure. In adults, in some adults, I do as well palatal pressure, okay? But when I have to decide between skeletal anchorage or palatal pressure, it depends on if I need to start in the upper arch, because I cannot start in the upper arch with brackets if I have the bonded one, okay, the palatal pressure one. This is the situation that I decide to put skeletal anchorage, okay. But for my point of view, it's the same change, okay. Is the same. The aperture of the shutter is the same. If I give more turns, I obtain more distance, but it's the same. Okay, I'm going to finalize. I'm going to finish the Instagram one. Okay, hello from Bulgaria. Expansion appliance that you used with the maxillary expansion is the moon expansion. Okay, Gabi. And the second question, and I finish the video because it's going to finish. Thank you. Only thank you. So there is no question. So I'm going to finalize the Instagram one, and I'm going to continue here in the webinar. I'm finalizing.
Dr. Francisco Erazo from Indianapolis says, thank you for a great presentation.
Thank you very much, Erazo, to watch me, to lose your time watching this webinar. Thank you.
Someone asked a question about a fixed hasp here, but it didn't complete the question. I'm trying to see what exactly, if they can repeat the question, that will be good.
Okay, they ask for the protocol. Maybe they ask for the protocol. I'm going to explain the protocol, okay? When I put the Miniscrew expander, okay, I give 6 turns a day until I break the shutter. And after that, I give 1 or 2 turns a day. Okay, this is my protocol with a skeletal anchorage. When I use palatal pressure, I give 1 turn a day until I finish the expansion that I want to make. Okay.
Okay.
I expect to answer exactly the question that he asked me.
I had one last question here. Can you use the motion elastic protocol in conjunction with the expander on adults?
Yes, for sure. There is no problem. You can make the disjunction and you can use the motion, and you are going to change the occlusal plane. You are going to have very, very, very good advantages when you combine, better than even if you start with brackets. I prefer to start with disjunction and class 3 motion in Spain because Spanish people, is also true, we have lots of maxilla deficiency. If you don't see maxilla deficiency, you have to put brackets or anesics in the upper arch and class 3 motion in the lower arch. For example, Dr. Carrier has less maxilla deficiency than in the south of Spain. Okay, it depends on the volume of the maxilla.
Okay, another question is for class 3 cases, do you like to use low torque brackets for the lower and high torque for the upper on class 3 patients?
Okay, you can do. Okay, you can do, but I don't recommend. Why? Because the SLX 3D is very accurate bracket. Okay, it's not a height slot. No, it's a small slot, 0.022 inch by 0.028, and you are not going to gain such amount of torque. It's not the same like in Damon. In Damon, you can lose and gain torque easily, but not in the carrier system. Our bracket is more accurate in the detailing because the slot is slower, is smaller. Okay.
Okay. They also say, do you have a good response in adults patients about sleep apnea not getting or not receiving relapse after treatment?
Okay,
What is
good
your
question.
experience on that?
Very, very good question. When I have a sleep apnea, okay, I have to see if the sleep apnea is height, is moderate, or is slow. Okay, is low. If there is height, I recommend the CPAP. Okay, I recommend the CPAP even if I treat the patient because it have is depend on not only it's not only depend on the maxilla and the jaw, depend on the, for example, the fats of the patient, depends of many circumstances that we cannot control. So in adults it's more difficult to improve the airways considerably in a patient. Okay, so I make this exactly the same treatment protocol, but sometimes I need to add after the treatment protocol the CPAP. Okay, or for sure the surgery solution, bimmaxillar surgery.
They're asking here, do you use a retainer after you achieve the class 1 or you continue with brackets automatically?
If I put a retainer after the class 1, okay.
Yeah, if you using the motion, you just move forward.
I like to put perfect. I like to put how do you say lace back in the lower arch between 6, 5, 4, and Canine, and I usually use from the lower first premolar to the upper first molar short light elastic at night in order to maintain what I did in the last phase. Okay, this is the best option to maintain what you reach.
Someone is asking here, have you used or do you use the Moon's expander that is sold in the US through Great Lakes?
If I use the Moon expander?
Yeah.
Yes, I've already saw one patient with Moon expander. I know Moon, and I know Ramon Monpel is a great practitioner here in Spain, and I follow their protocols. So I like it.
Do you like SLX brackets or SLX 3D better brackets?
I prefer SLX 3D. Why? Because I'm going to put you a slice, and you are going to see in an easy way. Okay.
Okay. They're also asking me, do you think you finish your cases faster because you use indirect bonding with CBCT and scans?
Yes, I'm sure. Look at this. Why SLX? Okay, I gave a webinar yesterday, and I explained exactly that question. Look at the bracket in the microscope. Look at the slot. The slot is not square. It's not 90 degrees. So this is less friction than the SLX. And when you see the door, okay, the door is very, very smooth. So for the patient it's easier, for me it's easier, and the door, the door that you open and close in the bracket is wide enough in order to make the rotation control. So for me, the SLX3D is the perfect bracket. It's the bracket that I was looking for to finish faster my treatment, to do the most efficient orthodontics that I can expect. This is the answer that I give. And for sure, if you do indirect bonding, if you use CBCT, if you use intraoral scanner, you are going to be more accurate and you are going to finish faster. Why? Because we finish slower when we have mistakes, when we make mistakes during the treatment. If I make a bad bonding, I lose 1, 2, or 3 months. If I have to, it makes me to make bends in order to solve problems about bonding. So all of that situation that I suffer during the treatment makes me lose time. It's not bad for the patient. The patient don't suffer that, but they lose the time, and the time is very important. Okay.
Here we have a question that you and I discussed, I think, in the previous webinar. How long does the carrier motion class 2 or class 3 cases, how long the treatment lasts? 5 months or it depends? I think when we answer this type of question, we always have to talk to colleagues is, what is your elastic protocol? How are you using the elastic? So how normally you handle this?
In class 2 patient, I change 3 times a day the elastics from the beginning, okay? And I use force 1 the first month in class 2, and after the first month, force 2. Force 1 is 1/4 inch and 6.5, okay? 6.5 how do you say inch, no? Or thumbs. How do you call the inch? Okay, sorry, I repeat. The first month I use force 1. Force 1 in order to correct the class 2. The force 1 is 1/4 of thumbs of the distance, okay, and 6.5 ounces of force, okay. And the force 2 is 3 parts of 16 of thumbs of the distance and 8.5 ounces of force. So first month, force 1, second month, until I finish, until I correct the class 2, force 2. In class 3 patient, force 1 from the beginning until I reach the class 1 platform, okay? I never use force 2 in class 3 patient because I can solve in a predictable way with the first force, with the force 1. And it's really important to use 3 times a day the elastic, 3 different elastics a day. We change each 8 hours, okay? Because the force of the elastic is losing time to time, is losing during the process of the time, during the time, okay?
Yeah, I get that a lot. Most colleagues are so used to say to the patient, just change the elastic twice a day. But most professionals don't really understand the physics of the latex. Like most people don't know that latex start decreasing forces after 3 hours. So the motion requires a constant and a frequent force active, or the ligaments and the bone will start relapsing after 3 or 4 hours. Here we have another question. When you have a patient that is not longer growing, but is still a class 2 malocclusion, do they actually get mandibular growth with the motion appliance?
When there is no growing patient, you are not going to obtain growing, okay? You are going to obtain dental-alveolar change, okay? And you can obtain also a reposition. Reposition is different than growing. Reposition is 2 millimeters, maybe 3 millimeters because of the disc, but growing usually is 4, 5, 6 millimeters of change. So don't make the confusion between growing and reposition. I can obtain reposition in non-growing patient, but not growing.
Here I have, hold on, because I cannot see. For your female patient, that I think is one of your last cases,
Okay.
Did you do a surgical expansion on this patient, or did you do just regular expansion on your last
I
female
do
case?
MARPE, M-A-R-P-E, okay? Miniscrew Anchorage expander, palatal expander, okay? It's surgical because you have to put the screw, but they don't need to, the surgeon don't cut the shutter, okay? It's
Okay.
miniscrew assisted, but it's not surgical. It's not, they are not cutting the shutter.
Here we have a question from Ireland. Do you remove lower third molars on class 3 career cases?
Yes, I remove in the 100%. At the beginning, I didn't remove, and because of I didn't remove, now I remove because it's a problem during the treatment.
I have a question from South Africa.
Great.
A patient presented with dissatisfaction with the flat lower face profile after completing orthodontic treatment, had an upper and lower premolars removed. So I'm guessing they didn't complete the question, but I do get that question a lot.
Okay.
What do we do when we retreat patients that are missing already 4 bicuspid and they still on deficiency on their profile and they still very pretty much collapse, you know, in their or within their arches?
This is a really good question. I like to talk about that because when I make the extraction in the anterior area, in the premolars area, you lose volume of maxilla and you lose volume of jaw. Okay, when I make the extractions in the third molar area, I don't lose volume. Okay, so when I have to decide if I extract or non-extract, my decision is not about anterior or posterior. My decision is around extract posterior or non-extract. But I never, it's maybe in 1% of my patient I extract, but less than maybe 1%. But in the most of cases that I decide to extract, there is no question between anterior or posterior. It's always posterior extraction. Why? Because I don't lose the volume of the patient, and the volume of the maxilla and the volume of the jaw is really important for me. I don't like the people looks 10 years older than he should look. Okay.
I have another question. Normally, when you get retreatment cases and they show up with 4 bicuspids out, so you already look, the premaxilla is deficient, the profile is very deficient. How often do you recommend them to reopen the spaces and place 4 implants to really balance their face?
Okay, this is a discussion that I have with Luis Carrier, for example. I remember I have one case you are going to see here. I'm going to show you, okay? Kuwait. I give this in Kuwait, this presentation. Look at, I think I have here the patient, and I'm going to show you the patient here. And it's very, very interesting to when you recover the space, because I like to recover sometimes, okay? When I recover the space, this is the patient, okay? From here, look at upper bicuspids, okay? The upper bicuspids, the first upper bicuspid are missing, okay? Extracted when she was young. Look at the finish. Look at the
So did you
finishing,
actually
okay?
open the spaces? Yeah,
I
okay.
open the space. Why? But the opening is not in the sagittal area. The opening is, I open the shutter, okay? And I develop the arch. So I don't believe in the creation of bone in the sagittal, okay? It's not going to create here. It's going to create here. If I do this and I move my teeth like that, I'm going to recover the space. If I do only this, I'm not going to recover the volume. The only way to recover volume is opening the shutter. Okay?
So
But I like to
transversal,
recover.
transversal and mesial, just to make sure
Exactly.
the volume comes back to where it's supposed to be and keep it balanced.
Exactly.
Pretty good answer. We have a question from India.
Great.
Can you please mention about suture patency in that adult male? They didn't type correctly. Have you used an arm instead of Moon's appliance, or how do you treat that case?
Okay, I use a has screw
Yes.
with acrylic in the palatal area in order to make pressure in the palatal area and open with this pressure, open the shutter. Okay, making one turn a day until I finish my disjunction. This is my protocol. This is the protocol that I use.
Someone here, I'm guessing they haven't seen you much with the motion appliance. What do you do if you need extractions? And here you can actually give us a better idea. Are you a doctor that do extractions at all? Or did you eliminate all your extractions period? Or when do you
No?
actually draw a line and say, listen, you do need extractions, motion, expansion, all of the above?
Yes. I do extractions. If I have to make extraction, imagine that the doctor, okay, who asked this, imagine that you make extractions in the 50% of your cases, okay? I recommend you to make the extraction in the third molars. You are going to have more space than if you extract the first premolar. One first molar is 1 centimeter. One third molar is 1 centimeter. One premolar, it's 8 millimeters, maybe 9 millimeters. So if you need the space, take the posterior. Don't go to the anterior. This is my answer.
Okay. I guess someone here still have a question. How you decide to do a removable or traditional expander? So I think you answered that question. You go pretty much,
Yes,
I think over 90% they're fixed. You don't do any removable expansion.
exactly.
Okay, this is a pretty good question with this new technology. How much worse in orthodontic treatment you consider that is doing orthodontics without a CT scan versus traditional diagnosis?
Okay, you can do orthodontics without 3D, but you are losing a lot of information. Okay, some decisions I made due to the 3D. I don't decide to expand. I don't decide to put brackets, and I go first to the PERI. So some decisions are making because I have the CBCT. I completely sure that you can good orthodontics without CBCT, but you don't have the same information than me. You have less information. So the thing that we need to know is that the CBCT, the intraoral scanner, a good quality photos, the only thing that don't makes us better orthodontics, give us more information, and we can decide what we do, but we have more information. We are free to decide, okay?
Yeah. I always answer to when I do lectures and I said, CBCT and not CBCT is like running at 30 kilometers, with an eye cover. And,
Yeah,
and
yeah.
you're going at 30 kilometers an hour, yeah, you can turn around, you can still see, but when you open the two eyes, now you can have a
True.
better view of the entire
Completely
spectrum.
true.
That's pretty much
Exactly.
the way I see it.
Exactly. Yes. But the thing is, a lot of people think that they don't do good orthodontics because they don't use CBCT. No, no, they are very good for orthodontics, but they will be better. They would be even better orthodontics if they have more information. Okay, this is the answer.
Especially now with the new approach of understanding that orthodontics are more than just moving teeth around.
Exactly.
Finally, we
Exactly.
see the repercussions of the airways, the direct impact is not even indirect or collateral. The direct impact of doing orthodontics and how
Exactly.
we affect the airways. That is impossible to see on a cephalometric or panoramic x-ray. That's something we need to be honest with ourselves. It is impossible to diagnose. I also have a question here. What is the oldest patient you have treated with expansion? With the
Okay, maybe 55 years old.
55?
But why? Because I don't usually have 70 years old patient. I don't usually have. And when I have, it's difficult to treat them because they have extraction before, they have implants, they have some situation that don't make me think about make expansion. It's not because of the age. It's because of the way, it's because of the type of the shutter. I always say that I only expand in the type A,
Okay.
B, and C. Okay.
Someone here doesn't have clear, what do you mean by doing extractions on the third molars to find more space?
Okay.
I guess they do not understand that it's very important to preserve your anterior bone density versus looking on this,
Okay.
floor space on the posterior.
Okay, I'm going to explain. I think I'm going to explain very clear. Are you watching my screen? No?
Yeah.
Okay, I'm trying to explain here. Okay, 3 molars and 2 premolar. You see here? You can decide. You can decide. I'll try to. I don't know if I can put here. Okay, maybe here. Here. You can decide to remove this. Okay. If you remove this, you are going to send all of this in this direction.
Backwards, yeah.
All of this back. Okay. Good. If you remove this is not going in this direction. This is going here. Or maintain or going here. And you have the possibility to correct the class 3 like this. A little change, this, give torque here, and don't lose soft tissue. Okay? So when I decide to extract, even in a big protrusion patient, you do like this. Okay, and you maintain the torque, and you don't lose here. Or if you want to lose here, you don't maintain the torque. It's easy. With the elastics, you can send everything back. Okay, this is what I decide when I don't want to lose volume here. Okay.
I think this question comes a lot is from the previous practice of distalization in segments. For some new practitioners, it's very hard to understand that it's better to move a third molar and move from the cuspid to the first molar as a segment, to go back and be able to preserve the anterior volume, because they're still in their head thinking, well, if I remove the third molar, that means I have to move the second, and then the first one, and then the second bicuspid, and then the first bicuspid.
It's easy with the motion. Exactly. With the motion, it's easy. You can do easily.
Yeah, it's a segment. We don't have to go one by one. That's the part that they just don't
let me, the one who asked this, let me show this. Look at, this is a good example, okay? Look at this page. You can decide to extract the first premolar, the lower first premolar, the left one, you see? Because you have the canine and you don't have space, okay? But it's better for me if you extract this one. If I extract this one, what I'm going to do? I'm going to recover the space, okay? Look at, I'm going to recover this space, sorry, and look at my patient at the end of the treatment. And look at my canine at the end of the treatment. Here I have my canine in the right position, and the space that I've used is the third molar space. I put all my posterior area back. I put my canine inside, and now it's an easy case to solve after the first phase, after the motion, okay?
Someone is asking here, any suggestions on the size of the screws that you normally use for the surgical expansion?
Okay, the recommendation is
not surgical,
at least 10 millimeters of length, okay? We need length of the miniscrew. If we have less than 10 millimeters, maybe can remove easily.
And the width, do you prefer any particular
width? The width, I think it's 7 millimeters. I don't make disjunction more than 7 millimeters of width. Okay.
I guess this is the last question. I know it's late for you. I wanted to ask you about mobility of the teeth while using the carrier motion.
Okay. The mobility is high for sure, because I expected the teeth to move. When you remove the class 3 one, when I remove the class 3 motion, I'm going to have high mobility of the canine, like that. Don't be afraid about that, because when you put brackets in 1 month, and the canine is going to recover the mobility, the normal mobility, maybe 1 millimeter, okay, not 2 millimeters, 1 millimeter, like the premolars or other teeth. So don't be afraid about the mobility. The mobility is something that is inside the process, and it's not dangerous for the canine. I've never made danger in a canine, never. Okay.
Plus, it's also necessary because most class 3 cases that incline,
exactly.
And then you have to level the curve of the speed and the occlusal. Well, Dr. Colino, thank you so much for this presentation. I know it's late for you.
Welcome.
Thank you so much.
And thank you for all the people to stay here and to see the presentation. I try to make a small presentation because now we don't need to stay 3 hours sitting again, because we spend all the time in the sofa. Okay. So thank you for everyone to attend to this webinar. And I hope to see you maybe in the American Symposium, or in the Asia Symposium, or in the European Symposium soon. Okay.
Perfect. Thank you, everyone. And please, everyone, stay safe and please stay home. Thank you so much.